Kavita
This
brought to
conference will now
hospital
be recorded.
by her mother Kavita with good reliability. The child presented with increased paleness of skin since 10 days and decreased activity since 1 week.
Okay.
History of present illness. The child was apparently normal 10 days back. Mother noticed paleness with insidious onset 10 days back, which is gradually progressive. Decreased activity of the child is since 1 week. It is associated with fatigue. No history of fever and chills. No history of pica. No history of shortness of breath. No history of bone pain and weight loss. No history of...
1 minute. Just hold on. You are telling the age is 7 months.
Yes, sir.
Can you ask history of pica in a 7-month child? Child does not have a choice, no? 7-month baby, it is dependent on the mother for feed. So unless the mother feeds pica-like things, history of pica will not be positive, isn't it? So you don't ask at that age.
Yes, sir.
Okay.
No history of dark colored urine. No history of bleeding gums. No history of diarrhea. No history of blood loss in stools or in warm tests. No history of passing worms in stools. Systemic review.
No, wait one. Hold on. Now, can you explain the symptom? What is that paleness correspond to? What is your inference for paleness?
Paleness of palms and soles.
Means what?
For grade 4 anemia, sir.
So where is the problem? See, first is system localization. So that means we have to say which system is involved. So is it fitting into the cardinal symptom of one of the major systems? So pallor, so paleness, we are telling. So paleness is a symptom of which system?
Hematological
system. Okay. So basically that means that the hemoglobin is low, isn't it?
Yes, sir.
So whatever the cause for low hemoglobin, we don't know. But in all causes for hemoglobin, where hemoglobin is less, you will have paleness, isn't it?
Yes, sir.
So basically, paleness means low hemoglobin. Okay, so that is why you are localizing it to the hematopoietic system. Can you tell any other condition where paleness can occur? So paleness means basically you are taking low hemoglobin means anemia you are telling. Any other condition other than anemia where pallor can be there, paleness can be there?
Hemorrhage.
Supposing child is in right, so in shock. So in any kind of shock, also you can have paleness of skin.
Yes, sir.
Usually these patients are seen in the ICU, not sitting in the OP. They don't come to the OP. So such situation is seen in the ICU. Any other conditions?
Yes,
Supposing, let us say, you have a child with nephrotic syndrome and you look at his conjunctiva and the conjunctiva appears pale, but actually his hemoglobin level is normal. How do you explain that? Anybody can answer.
Erythropoietin production.
No. Erythropoietin means again it comes to hemoglobin only. No. See, I am telling you the hemoglobin is normal. So in a edematous state, whenever you have edema, what happens is the capillaries are flushed out. So the capillaries in the conjunctiva, when you are seeing the palpebral conjunctiva, they will be flushed out. So that's why they will appear. Hands also will appear pale. So actually there is no decreased hemoglobin, but there will be appearance of pallor. Okay. So paleness doesn't mean that definitely hemoglobin is low. So these are the
Yes, sir.
conditions apart from apart from a low hemoglobin. Remember shock as a cause of paleness. Remember also edematous states like nephrotic syndrome also as a cause of pallor. So you have asked different questions regarding the second symptom was you said he was getting fatigability. What does it mean? What is the
Ox
inference? It indicates the level
hypoxia.
of hemoglobin. It indicates the severity of the problem. So it indicates the level of hemoglobin. See, mildly, if the hemoglobin is reduced, child will not, usually will not have any symptoms. But when there is a severe reduction, definitely there will be associated fatigability, sweating, tachycardia, palpitations, all that will be there. So that indicates the severity. So there are two things you have told. One is mother noticed the pallor. The second is there is also easy fatigability also you said. Okay. So now you have
Yes,
asked
sir.
some questions and you tell why you have asked those questions. Each question you tell and you also tell why you have asked them.
Sir, fever and chills to rule out any malaria.
Okay. So that means infection you want to rule out. So among the commonest
Infections.
infection is malaria. Yes.
Malaria, sir.
Yes. Good.
Shortness of breath to rule out cardiac failure.
So you are
Cardiac.
thinking it doesn't belong to the hematopoietic system, but
CVS.
the breathlessness belongs to CVS. So that means you have to ask for 5 symptoms. Karan. So what are the 5 cardinal symptoms of cardiovascular system involvement?
Palpitations, chest pain,
Yes.
breathlessness,
Breathlessness. Yes.
um, sign,
Edema and sweating,
Cyanosis.
sir.
Yes.
edemas,
Cyanosis. Cyanosis. Not edema. That is sign. Symptom only I am asking. Cyanosis is a symptom. Yes.
sinuses,
And
syncope.
syncope. Right. So all this in one continuous line you should tell. So which means that this does not belong to the cardiovascular system, but it belongs to the hematopoietic system. Okay. Next.
Sir, bone pain and weight loss to rule out any malignancies like leukemia and lymphomas.
Yes. Good.
Hematuria or dark colored urine to rule out
Hmm.
any hemolysis or urinary causes.
Okay. So hemolytic anemia you want to rule out. So hematuria you will get in hemolytic anemia. Only in massive hemolysis you will get. Otherwise, not necessarily. Okay. Next.
Um, bleeding gums.
Hmm.
Bleeding gums are seen in aplastic anemia, sir.
Okay. Good.
Diarrhea to rule out
Hmm.
any malabsorption syndrome.
Malabsorption. Yes.
Blood loss in stool or in vomitus to rule out any GI bleeding.
Okay.
Passing of worms in stools to rule out any
Hmm.
worm infestations.
Which worm did you ask him? Are all worms
Hookworms,
capable of? So is the hookworm visible to the naked eye? Which worm is visible to naked eye?
No.
Is the
Tinea.
ascaris which is
Tinea
visible.
soleum.
Tinea soleum and ascaris are visible. So hookworm is usually small, so it's not visible. So you have to investigate for that, and you suspect in the history, and in the investigation you confirm that. Okay, next.
Systemic review. Cardiovascular system. No history of shortness of breath. CNS. No history of seizures and irritability. Respiratory system. No history of cold and cough. GIT. No history of diarrhea and jaundice. Genitourinary. No history of burning micturition and no history of hematuria. Hematological paleness of skin is seen and easy fatigability is present. Hepatobiliary. No history of hematemesis and jaundice. Musculoskeletal system.
Any
No
history of blood
history of
transfusion I have asked them?
yes sir.
Okay.
No history of blood transfusions.
So if history of blood
Musculoskeletal
transfusion is there, what information will it give? When do we give blood transfusion? At what level do we give blood transfusion?
It is also given in hereditary spherocytosis.
That is different. What condition? Not conditions are list of conditions are there, but generally, when child comes to the ICU, depending upon
Severe
the
anemia.
levels, severe anemia. What is the cutoff point for giving blood transfusion? I am asking. Usually
Less than 5.
5. Yes, 5 or below 5. Because why should we give blood transfusion below 5 or 5? Because child can go into spontaneous failure. If you don't bring the hemoglobin above 5, child can go into spontaneous congestive cardiac failure due to the anemia itself. So that is the reason urgently we give fat cell transfusion. Okay.
Musculoskeletal system. No history of skeletal deformity. No history of limitation of range of movements. Reticular endothelial system. No bleeding gums. Eye, no redness and discharge is seen. In ear, no ear discharge is seen. Skin, pale skin is seen. No rash is present.
Okay.
Past history. No similar complaints in the past. No history of blood transfusions. No history of any surgeries. No history of joint swellings.
Okay.
Antenatal history. Age of mother at conception is 21 years. Registered case of para1 live 1. Antenatal checkups were regular. Two doses of TT were given. Iron and folic acid tablets were taken during pregnancy. No history of radiation exposure. No history of no drug history.
Okay.
Natal history. Natal history, term gestation. By normal vaginal delivery at baby was delivered by normal vaginal delivery at GGH Kakinada. Birth weight of the baby is 2.5 kg. Cried immediately after birth. Breastfeeding was given immediately after birth.
To increase the hemoglobin content in the baby, what natal procedure should we do regarding cord clamping?
Delayed umbilical cord clamp.
Yes. So cord clamping should be delayed. Okay, good. Next.
Postnatal history, no history of neonatal jaundice, and no feeding abnormalities. Family history. Third degree consanguineous marriage. No history of similar complaints in any other family members.
If there is neonatal jaundice, what will you suspect?
Sir, in hemolytic diseases,
Yes. Hemolytic. What
jaundice
is the
is
commonest hemolytic disease? What is the commonest hemolytic disease?
enzymeopathies.
Enzyme is rare.
RH incompatibility, ABV
Yes,
incompatibility.
yes. ABO only, now it is common. Previously RH was common, but nowadays we are doing RH test to everybody who is getting pregnant. So that's the reason why they are giving. What is the drug they are giving to prevent RH problem? If mother is negative, what drug is she receiving?
Anti-D immunoglobulin.
Anti-D immunoglobulin.
Anti-D. Yes. Yes. Anti-D she is receiving. So the RH problem has been solved. So now the ABO incompatibility is there, which we cannot prevent because that is the natural blood groups. So that is one. So apart from that, spherocytosis is the, among the membrane defects, spherocytosis is the most common.
Yes, sir.
Okay. Congenital or hereditary spherocytosis is the most common. Right. Next.
Developmental history, gross motor, sitting with support, fine motor, radial palmar grasp, social milestones, stranger anxiety is present, language milestone, child is using monosyllables, developmental
Okay.
quotient is 100%.
Hmm.
Immunization history, at birth BCG, OPV and hepatitis B were taken. At 6 weeks, pentavalent 1 and OPV 1 and rotavirus 1 were taken. At 10
What type of OPV is given now? What type of
bivalent
OPV is given? Bivalent OPV. What bivalent means? What does it contain? What has been excluded? There are three types, no? Type 1, 2, 3. So bivalent means what is
Type 2
excluded?
is excluded.
Yes, very good.
2, sir.
Type 2 is excluded. So what is left is 1 and 3.
1, 3.
Okay. Continue.
At 10 weeks, pentavalent 2 and OPV 2 and rotavirus 2 were taken. At 14 weeks, pentavalent 3, OPV 3 and rota 3 were taken. IPV was taken at 6 and 14 weeks. Social history.
So OPV was given and IPV was also given.
Yes, sir.
Both. So what is the zero polio? Which dose
Sir?
is called a zero polio dose? Which dose of polio is called a zero polio dose?
Birth dose.
Birth dose.
At birth. That which is given at birth is called as the zero polio. What is the color of the polio vaccine? Have you seen the polio vaccine? Oral polio vaccine? Pink in color. Yes. How many drops should we give?
2 drops.
2 drops.
2 drops. So there is a monitor which checks the potency of the vaccine, whether it's viable or not. What is that called as?
Vaccine vial monitor.
Vial
BVM.
monitor.
How to read the BVM?
If the central circle becomes dark, central square becomes darker, we have to discard the vaccines.
Even if it has become same color also, you should discard. It should be lighter in color than the surrounding circle. Okay. Continue.
Social history, the child belongs to upper lower class as per modified Kuppaswamy classification. Dietary history, exclusively breastfed till 6 months of age. Complementary feeding was started at 7th month. Before illness, total calories taken were 550 kilocalories. Required calories are 560 kilocalories. 10 kilocalories were deficit. Total protein intake was 10 grams. Required is 12 grams. Deficit is 2 grams. General examination. The child is conscious and sitting comfortably on her mother's lap. Pallor is present. No.
Where all did you check for pallor?
Lower palpebral conjunctiva, dorsum of the tongue, nails, palms and soles.
So if in the exam you are asked to check for pallor, what else will you do? Demonstrate pallor. If you are asked to demonstrate pallor, what will you do? You have to compare with what? Take the hand of the patient and compare with palm with your palm.
Sir.
So you have to show the contrast, assuming that your hemoglobin is normal. You are also having pallor means that's a different issue. But normally we expect you are normal and the patient is having pallor. So that contrast will be visible. So that's how you are supposed to demonstrate in the exam. Okay. Next.
No icterus is present, no cyanosis, no clubbing, no generalized lymphadenopathy, no
So what are
pedal
the
edema.
types of icterus? What are the types of icterus you see? Mild. You have got some description for icterus. Where do you see mild icterus, lemon color icterus?
Kramer
Where
scale.
do you have deep yellow? Not that one. In the eyes I am telling.
Sclera.
Sclera only. Supposing the icterus is mild yellow, what is the diagnosis? If it's deep yellow, what is the diagnosis? If it is greenish yellow, what is the diagnosis? So if you are thinking in terms of a pre-hepatic, hepatic, and post-hepatic cause. Yes. So pre-hepatic means a hemolytic cause. So hemolytic cause usually will have a very mild jaundice or maybe absent also. Whereas a hepatic cause will have a deep jaundice, deep yellow. Whereas a obstructive jaundice will have a greenish tinge. So based on these colors, we can tell whether it is pre-hepatic hemolytic or is it hepatic jaundice or is it post-hepatic obstructive jaundice.
Yes, sir.
Okay. So next.
No hyperpigmentation of knuckles and koilonychia is seen.
You have to tell platynachia first because koilonychia takes a very long time to occur. First, platynachia means flattening.
Yes, sir.
Platynachia is an earlier sign. So what does platynachia indicate or koilonychia indicate?
Iron deficiencies.
Iron deficiency. Supposing yesterday there was bleeding. He has lost blood and iron. Tomorrow he will develop koilonychia.
No, sir.
So what should you tell? Answer should be chronic iron deficiency anemia. Yes, that should be the answer. Not acute iron deficiency. So is there any differential diagnosis for koilonychia? Any other condition you see koilonychia? So there is no other condition. It is very specific for iron deficiency anemia. Chronic iron deficiency anemia. So whenever you see this platynachia or koilonychia, immediately you have to see the tongue also. What will the tongue show if there is platynachia?
With papillas.
What is the classical tongue
Ball
called
tongue.
as? Yes, pale ball tongue. So whenever you have this combination of pale ball tongue with Leishmania or Chylomicronemia, definitely the child is having chronic iron deficiency anemia. So in your investigation, in the peripheral smear, you should expect a what type of anemia? Peripheral smear should show what type of anemia?
Microcytic hypochromic.
Microcytic hypochromic anemia. Yes, microcytic hypochromic anemia. Yes. Yes, continue.
Vital data, temperature is 98.4 degrees
No other
Fahrenheit.
finding? No other finding in general examination?
No, sir.
No lymphadenopathy, no pedal edema,
No,
nothing? No clubbing?
no, sir.
Okay. Vital
ఇన్కమ్
data?
ట్యాక్స్ డిపార్ట్మెంట్ రాసింది ఇదే.
Hello, somebody's microphone is unmuted. Please, other than the speaker, presenter, others, mute your microphone. Okay, continue.
Pulse rate 110 beats per minute. Normal rhythm and normal volume. No radial and radiofemoral delay.
Okay.
Respiratory rate is 30 times per minute. Abdominothoracic type. Blood
Okay.
pressure is 90/60 mmHg in seen in supine position in left arm. Oxygen saturation is 98%. Capillary refill time is normal.
Okay.
Anthropometry, height of the child is 66 centimeters and weight is 6 kg. Weight for height is 6 kg for 66 centimeters. Head circumference is 39 centimeters. Mid upper arm circumference is 12.5 centimeters.
4.5.
12.5, sir.
12.5.
Head to toe examination. Head is normal shape and sutures and fontanelle are normal. On eye examination, eyelids, eyelashes, eyebrows and palpebral features are normal. Nose is normal. Mouth, lips, buccal mucosa, teeth and palate are normal. Tongue is pale. On neck examination,
So,
trachea is in midline.
what is the type of face you see in a condition where we are expecting hemolysis?
Hemolytic faces. Chipmunk
So,
face, sir.
so, what are the features of hemolytic faces?
Frontoparietal bossing. With hot cross bun appearance of the skull. Malar prominence is seen. Malocclusion of teeth with protrusion of maxillary teeth.
What happens to the bridge of the nose?
Depressed bridge of the nose.
Right. Continue.
Systemic examination. On abdominal examination, inspection, shape and size of the abdomen are normal. Skin color is normal. Umbilicus is in midline. Midway between xiphoid and pubic symphysis. Inverted and no discharge is seen.
What are the different
All
shapes of the
quadrants move
umbilicus?
equally. Smiling face sign is or transverse slit is seen in SIT, sir.
Yes.
In obesity, deep cleft is seen, sir.
Deep. Yes. If it is everted, what will you think of?
Organomegaly, sir.
Yes.
Oh,
Organomegaly. So
organomegaly.
solid organ enlargement. It could be either a big hepatomegaly or a big splenomegaly. Okay, continue.
All quadrants move equally with respiration. No visible peristalsis. No scars are seen. Tone of the muscles is normal. Inspection of the back is normal. Uh, palpation. On palpation, no local rise of temperature. No tenderness is seen. No rigidity and no guarding is seen. Palpation, sir. Liver palpation. Liver is enlarged, soft in consistency, uh, smooth surface, non-tender. Uh, Lower border is palpable up to 3 centimeters below the costal margin. Uh, on
How is the
spleen
border?
examination,
How is the
sir.
border of the liver? How is the border? Sharp or rounded? Where do you get sharp border?
Mm,
Cirrhosis, yes. Rounded border, normal liver.
yes, sir.
Okay. Spleen?
Yes, sir. Spleen is enlarged. Tip is palpable at the umbilicus. Non-tender, soft in consistency and smooth surface.
Why we should take even tip as very significant for spleen, whereas tip of liver we don't take significance. Why?
Um,
Tip means already spleen has enlarged 3 times.
yes, sir.
So by the time tip is palpable, spleen is already enlarged 3 times. That is why it is very significant. Liver means if it's enlarged also, it can be a push down liver. So that is why we have to measure the span of the liver, which we will do in the percussion.
Yes, sir.
Okay, what is bimanual palpation? Of kidneys?
We keep one hand on the anterior abdominal left side and another hand back, and then we push the other hands into the abdomen so that kidneys.
Okay, so what is the term you use for that?
Ballotable.
To differentiate it, ballotable. So why do we say it is ballotable? Kidney is ballotable. Why do we say? Because ballotability is the term which is used in your obstetrics, isn't it?
Retroperitoneum.
The
Pair of
head,
fats, perinephric fat.
you have the head of the fetus and surrounding fluid is there. You tap the head, then it goes and touches the other opposite part. So that means a solid organ is moving in a liquid. Now you are using the same term ballotable for the kidney. I'm asking where is the fluid in which the kidney is moving?
Retroperitoneums.
What is that?
Retroperitoneum.
Retroperitoneum is there's no space at all in retroperitoneum. Retroperitoneum is peritoneum only. There is fluid. All of you have done dissection, no? What did you find around the kidney in the cadaver?
Fat, sir, perinephric pad of fat.
Yes, yes. Perinephric pad of fat. In the cadaver, you found it as a solid, whereas at 37 degrees, when the person is alive, that is a liquid. So that is what is giving the bloatability. Got the point?
Yes, sir.
Okay. So that is why we say kidney is bloatable. Okay. Next, continue.
On percussion, no fluid accumulation is seen. Liver span is 6 centimeters, sir.
Liver span is 6 centimeters. So is it normal or abnormal for that age?
Sir, up to 12 years, 6 to 12 centimeters
No. You
liver
have to tell
span is.
his child is only 7 months only. So you have to tell for 7 months
Yes,
child. For 7 months child, 6 centimeter is normal, abnormal.
abnormal.
Abnormal. It's enlarged. So there is hepatosplenomegaly is there. So we have positive signs. Pallor is there, hepatomegaly is there, splenomegaly is also there. Okay, very good. Next.
On auscultation, peristaltic sounds are normal. No venous hum, no arterial bruit, no friction sound, no suction splash.
Hmm.
Other systems examination. On CVS, normal S1 and S2 sounds. No murmurs
See,
are
if you have
heard.
so much pallor is there, in CVS you will expect some murmurs. What are they called as? In
Unique
anemia
murmurs.
cases, severe anemia, hemic murmurs, yes, hemic murmurs are expected, and also because anemia is there, you can expect tachycardia. So don't tell there is no tachycardia. Definitely there will be tachycardia whenever there is decreased hemoglobin.
Yes, sir.
Hmm. Okay, continue.
Mm. Respiratory system, trachea is in midline. Normal vascular breath sounds are heard. CNS, normal higher mental functions, normal motor and sensory functions. Hematological signs of anemia are seen. Lymphatic system, no lymphadenopathy is seen.
So what is hemolytic triad? Hemolytic triad. What is hemolytic triad? Three things. Triad means three.
Anemia,
What are the three things?
jaundice, and splenomegaly.
What is that? Pallor?
Anemia, jaundice,
Pallor?
and splenomegaly.
Jaundice,
Yes.
splenomegaly.
Anemia, jaundice, and splenomegaly. Now, in this child, what is there?
Pallor and splenomegaly are there, sir.
Splenomegaly is there. Jaundice is not there. Okay. So, can we think of hemolytic anemia in this child?
Yes, sir.
Yes, we can think because jaundice is not necessary. It can be mild jaundice, especially in hemolytic anemia. It is very mild, sometimes so mild that it can be missed also. So, because of the hemolytic triad, even two components are sufficient to suspect hemolysis. Okay.
Uh, Provisional diagnosis. A 7-month-old female child who was born to a third-degree consanguineous marriage came with chief complaints of increased paleness of skin since 10 days and decreased activity since 7 days, which is associated with fatigue. On examination, the child is having grade 4 pallor with enlarged liver and spleen with a liver span of 6 centimeters. Um, Most
So,
probably,
hmm, tell most probably.
a case of thalassemia with
Why you are
hepatosplenomegaly.
telling directly thalassemia? First of all, we should tell whether it is hemolytic anemia or not. Now, I am telling
Hemolytic
this is
anemia, sir.
the lesion is in the bone marrow. Why am I wrong? See, anemia means one cell line is gone. RBCs are not produced. There are two more cell lines in the bone marrow. What are the two cell lines?
WBC platelets.
Efficient platelets, yes. So now, if the platelets are decreased, what is the symptom? What is the sign?
Bleeding gums,
Skin or mucous
petechiae.
membrane. So, petechiae and mucous membrane bleed can present as a gum bleed or a epistaxis. So these two are not there. So that means clinically platelets are normal. Now what about WBC? What is the symptom of decreased WBC and what is the sign of
In
decreased WBC?
infections,
So symptom will be
fever,
fever. Sign will be where infection occurs, which is the most contaminated part of the body.
Oral cavities.
urinary.
Yes, it is not the perineum. It is the oral cavity which is the most contaminated part. So what is that specific sign which is diagnostic of neutropenia?
Ulcers in oral cavities.
Oral
Ulcer.
thrush.
Oral ulcer. Yes, oral ulcer. So did you look for oral ulcer? You have to tell this compulsorily this point in any case, any anemia case, in general examination, you have to tell there are no oral ulcers. If you are asked why, you should tell you are looking for signs of decreased WBC or neutropenia.
Yes, sir.
Okay. So first you have to prove that it is a hemolytic anemia. I will say that this is nutritional anemia. Why it is not nutritional anemia? Because nutritional anemia is the most common cause of anemia. So your nutritional history is important there. So otherwise your nutrition, what about the weight and the height? They are all
Koilonychia
normal. So Latinacea, pale bald
and
time,
child is
Pyelonechia,
not weight gain is
nourished,
normal, sir.
normal, yes. So there are no other nutritional signs of deficiency. So weaning also you should concentrate on the weaning foods, whether they are given properly or not.
Yes, sir.
Okay. So now because there is hepatomegaly, splenomegaly, which cannot be explained by the nutritional part, even so you are thinking in terms of a hemolytic anemia. So now to simplify the hemolytic anemia, we have membrane defects. So all membrane defects can be detected by the peripheral smear. So what are the membrane defects we have got?
Sickle cell
Spherocytosis.
anemia and hereditary spherocytosis.
No, only two. Elliptocytosis, stomatocytosis, pyropaglicocytosis.
Stomatocytosis.
All these things are membrane defects. So all this can
Membrane
be included or confirmed in a peripheral smear. Okay. So if this is not there, you think of a hemoglobinopathy. So what are the types of hemoglobinopathies you have got? Alpha thalassemia and thalassemias and sickle cell anemias.
beta thalassemia.
So further divided into alpha and beta thalassemia, which is again divided into minor, intermediate and major.
Beta thalassemia trite, beta thalassemia intermedia, majors.
So which one presents at the age of 6 months?
Major thalassemia majors.
Major. Yes. Why it presents at 6 months?
HbF is
Appearance of
lost.
fetal hemoglobin.
Yes. So for the fetal hemoglobin at birth is about 70%, whereas A is only 25%. So by 6 months, this fetal hemoglobin is no longer produced, and A has to take over. So if A doesn't take over, then fetal hemoglobin gets exhausted. So that is why you have the failure which is presenting at 6 months. So any condition which is presenting at 6 months, you have to think of a thalassemia, especially when it's associated with hepatomegaly and splenomegaly. So what test would you like to do for thalassemia?
Complete blood count, peripheral smear examination, uh, radiological examination.
So what peripheral smear will show?
Microcytic hypochromic
Hmm.
with
And one more
poikilocytosis,
with
basophilic stippling,
one more important thing. It differentiates it from the iron deficiency.
Target cells.
polychromation.
They have a nucleated RBC. So the presence of nucleated RBC differentiates it from the iron deficiency anemia. In iron deficiency, you don't have nucleated RBCs. So that is a suspicion. So then you do hemoglobin electrophoresis. So what happens to the electrophoresis? What is the normal pattern?
On hemoglobin electrophoresis, fetal hemoglobin is
A,
increased.
how much is A? Normally how much is A? About
90.
95%. Yes, 95%. More than 95%. A2 is 2.5%. And F
Yes,
is
sir.
less than 1% F. So because A is not produced, fetal hemoglobin will be increased. So which is again a indirect indicator that these beta chains are not being produced. Okay.
Yes, sir.
So hemoglobin electrophoresis has been done for this child.
Don't know, sir.
Don't know. Okay. So let us say you have done hemoglobin electrophoresis and the fetal hemoglobin is raised. And so what treatment would you like to give for this child?
Blood transfusion, sir.
So what blood transfusion will you give?
Triple saline washed packed RBC, sir.
Packed cell transfusion you would like to give. How much will you
180 ml per kg per year, sir.
give? No, that is a year. At a given point of time, each time will you give, how much will you give? Should be 10 to 20 ml per kg. So that your target, what should be the target hemoglobin? Where should you maintain?
10 to 12 grams
10 to 12 grams. Why should we maintain at that level?
to avoid failure to thrive, sir.
No, tissue hypoxia. Tissue hypoxia should be avoided because there will not be any tissue growth then. There will be failure to thrive. Not only that, there will be to prevent extramedullary hematopoiesis, which can
Yes,
result
sir.
in your hemolytic phases. So the hemolytic phases is actually due to the extramedullary hematopoiesis.
Process.
Okay, so if you keep on giving blood transfusion, what is the complication?
Plasma-borne infections, iron overload.
Yes, iron overload. So how will you know there is iron overload?
Endocrinopathy, like growth failure,
No. You don't wait for all those
hypogonadism,
things. What test will you do to know iron overload is
serum
Serum
occurring?
ferritin
ferritin
levels.
levels.
Serum ferritin level. So based on the serum ferritin, you would like to start anti-chelation therapy or chelation therapy. What is this chelation therapy? What are the drugs available?
Deferoxamine, defersirox, and deferiprons.
Different. Okay. So what are the complications? If you don't properly treat thalassemia, what is the problem?
Hypersplenism.
No, if you don't treat, what happens? You are not maintaining the hemoglobin levels. So what happens to the child? His height and weight will not be appropriate. So there will be growth failure.
Yes, sir.
And there will be delayed puberty. Okay. So there are complications due to iron overload also. What are the complications for iron overload? It can affect the
Growth failure, hypogonadism, diabetes,
yes,
cardiac failure.
cardiac failure. Okay. So is there any drug which is given in to stimulate the production of hemoglobin F?
Hydroxyurea.
Hydroxy.
Hydroxyurea. Yes. So what is sickling test? How to do sickling test? Anybody knows? So
In
what you do
hypotonic
is
salts, in hypotonic solution, if we place the RBCs, sickling is seen, sir.
no. The RBC will lyse if you place in.
Add a reducing
We'll
agent to
mix the
blood.
blood sample with
You want
metabisulfite.
to create a hypoxic atmosphere. Remove the oxygen. How do you remove the oxygen?
Reducing agent, sir. By adding a reducing agent.
What is that reducing agent?
Sodium metabisulfite.
Yes. So you add sodium metabisulfite to 1 drop of blood. You add 1 drop of sodium metabisulfite and wait for how long? Wait for 15 minutes. So in 15 minutes there will be 100% sickling. So supposing, let us say you are working in PHC, primary health center, and you don't have sodium metabisulfite, still you are suspecting sickle cell. How will you do this test of sickling? How will you demonstrate sickling in a primary health center? So what you should do is the method which is called as the cover slip. You take a drop of blood, you put cover slip on it on a slide, and then seal off this edges of the cover slip with Vaseline. So you leave it overnight. Then it creates a hypoxic atmosphere. So you read after 24 hours. Here in metabisulfite, if you add, you get the result in 15 minutes. Whereas there you have to wait for 24 hours. So that is how you do when sodium metabisulfite is not available. Okay. So the dosages of this deferasirox and deferriprone, all that, and the advantages, disadvantages, and cost, you learn from the textbooks. Okay. So any doubts
Yes,
are
sir.
there?
No, sir.
Anybody has got any doubts? So if there are no doubts, then we'll close the session.
Yes, sir.
Yes, sir.
Thank you, sir.
Thank you, sir.